First of all, I would like to thank you for inviting me or giving me the opportunity to present some work from the Erasmus Medical Center on immunodeficiencies in patients with Jacobsen syndrome. Ken, thank you for introducing the immune system, which makes it a bit easier for me to give this presentation. First of all, I want to get a little bit deeper into the functioning or normal functioning of the immune system, and then in the end show you what we did in a number of patients with Jacobsen syndrome in analyzing immune cell function and dysfunction and the potential clinical significance of these findings. So as already discussed by Ken, the main function of our immune system is defense. So defense against all kinds of invading microorganisms, bacteria, viruses, parasites, fungi. And how does it work? I have a very brief movie in which the green cells depict immune cells, and this red figure is a bacteria. And what happens in very short time is you see bacteria get ingested by cells of our immune system. So when invading microorganisms enter the bloodstream, get captured by immune cells, and immune cells get they get hold of the bacteria, destroy them. So they prevent us from getting sick. Or in case of disease, immune cells destroy bacteria or viruses, so you get better. Another short movie displays the normal functioning of the immune system.
It's very complex. Our immune system protects the body against intruders, such as bacteria and viruses. The skin is an important protection device.
Here, top right is the volume control.
Yeah, but I don't need the music. What happens in an infection? First of all, you get damage, for instance, to the skin, with a wooden splinter, for example. So you break the barrier of the skin. So it means that bacteria, viruses can enter your body because they break, there is a breakdown of the skin barrier. Bacteria, in this case, depicted with the pink figure, enter the bloodstream and they swim around. In the bloodstream, they encounter all kinds of cells of the immune system, like for instance the first defending mechanism, the macrophage. Bacteria produce all kinds of factors, as shown over here, which are recognized by cells of our immune system, in this case macrophages. And macrophages are cells that can phagocyte, also called phagocytes as mentioned by Ken, so they can recognize bacteria and they can destroy and eat them, as shown in this cartoon. So remember, the skin is our first line of immunological barrier. And then bacteria encounter immune cells in the bloodstream, in this case macrophages, which can directly eat the bacteria, but they can also send signals, we call it cytokines, to other immune cells. And other immune cells can react by helping macrophages to get rid of bacteria. So those are more specific immune cells than the macrophages. So the macrophage can eat everything that comes in, which is strange, that you recognize as being strange. Then the macrophage sends signals to specific immune cells that come into action and get rid of the bacteria. So this is a simplified cartoon or movie of how the immune system works upon breakdown of the immunological barrier, the skin. So we have the skin as a barrier, we have macrophages as first encounters of bacteria in the bloodstream, and specific immune cells called B and T cells. If you want to see a nice movie on how the immune system functions, because this is a very short movie, but if you are at home you say, well, this is a nice movie I found on the internet. This is something this is a movie I found on the internet some years ago. It's very easy. It looks a bit stupid sometimes, but I always show it to my patients at the outpatient clinic because it shows very clearly how our immune system works. It takes around 8 minutes, but then you exactly know what's happening in our immune system upon infection, and you can find it on the YouTube channel with this link. I can send you by email, or you can write down afterwards. Sometimes a bit for children, but it's really clear in how the immune system works. So, what about the immune system? The major organs of the immune system are depicted on this slide. There are various organs that are able to produce immune cells or can be a storage for immune cells. Most important component of the immune system I see as the bone marrow. So the bone marrow is the inner side of our major bones in which immune cells are produced. Not only our immune cells, but also the red blood cells, thrombocytes are all produced in the bone marrow, which is depicted on the slide over here. So immature immune cells grow in the bone marrow, leave the bone marrow, go to the thymic gland, which is located in front of the heart, or to the spleen. So this is a very complicated situation in which you have immature cells get out of the bone marrow, go to the spleen, then they become B cells, and go to the thymus, they develop into T cells. So the only thing I want you to remember of this slide, because it's important later on in my talk, is that you have immune cells, either B cells or T cells, all coming from the common progenitors in the bone marrow and differentiating into B cells in the spleen and T cells in the thymic gland. Of importance to remember from the B cells is that they produce the immunoglobulins, as already mentioned by Ken. And what are the immunoglobulins? These are Y-formed proteins that recognize antigens. Antigens are particles, parts of bacteria. And you see over here that all kinds of immunoglobulins have specific antigen recognizing patterns. So like for instance, in this antibody, only this specific antigen can bind. All the other antigens have a different structure, so they cannot bind to this antibody. So you can imagine in your body you have millions, billions of antibodies specific for all kinds of bacteria, viruses, etc. So you need an enormous amount of very specific antibodies for recognition of specific patterns. So how does it work? I have another short movie. This is the bloodstream, and you see millions of cells, red blood cells, bacteria, white blood cells, all kinds of cells are running through our veins and arteria. And this is a bacterium, and you see on the outside of the bacteria you have a certain structure, bacteria-specific structure. Macrophages can, for instance, recognize bacteria because of the outer structure of these bacteria. So you get direct control, and you have the immunoglobulins, which bind to specific compounds on the bacteria. And those antibodies are not alone specific to the bacteria, but they are also specific so that other cells can recognize the antibodies and can get rid of the bacteria. So the antibodies bind to specific bacteria and then can be digested and deleted. So what happens if you have defects in this kind of antibody production, of antibody formation? Well, as already mentioned by Ken, you get recurrent infections. An antibody deficiency, so shortage in production of antibodies or shortage in functioning of antibodies, leads to recurrent infections of the pulmonary tract, your nose, throat, sinusitis, bronchitis, pneumonia, and recurrent infections of the gastrointestinal tract. So sinopulmonary and gastrointestinal tract infections are the main infections caused by antibody deficiencies. And as already shown by Ken, around 50 to 60% of the known immunodeficiencies are predominant B-cell deficiencies, antibody deficiencies, characterized by a decrease in the production of immunoglobulins or function defects of immunoglobulins. So where is the defect? Going back to this picture, the bone marrow B cells differentiating in the spleen into mature B cells. Those B cells produce the immunoglobulins, the Y-formed proteins that can specifically bind to various bacteria. So if you have a problem with antibody formation, the problem is here in B cell development. They do not produce immunoglobulins, or the immunoglobulins they produce are not functioning as they should. What kind of clinical pictures you will see? Recurrent respiratory tract infections, as already mentioned numerous times, but also you can imagine that if you have recurrent respiratory tract infections, you get indeed organ damage. For instance, damage to the lungs. If you have recurrent infections of the lungs, leads to damage of the lungs. And this common variable immunodeficiency, which is characterized by defects in B cell function or antibody production, is one of the most predominant antibody deficiencies we know at current. So what about immunodeficiency in Jacobsen syndrome? As indeed already said by Paul, I got involved in Jacobsen syndrome in 2010 by Jiri Schouten, the son of the Ton Schouten, who was referred to my outpatient clinic. I'm doing the outpatient clinic for primary immunodeficiencies for adult patients. And he was referred to my outpatient clinic. This is an actual picture of his hands because of multiple recurrent warts all over his hands and his feet, and recurrent respiratory tract infections. This guy was needing antibiotic treatments for pneumonia, for sinusitis, around 6 to 7 times a year. So what did I do? I checked the function of his immune system, and what I found is indeed that he showed low antibodies, so low specific antibodies binding to bacteria, and a low number of T cells, which can explain recurrent respiratory tract infections and maybe the warts in this particular case. So we had low numbers of immunoglobulins, low numbers of T cells, and I treated this guy with immunoglobulin therapies, and since then he doesn't have any bacterial infections of the sinopulmonary tract anymore. And I don't know how that happened. All his warts disappeared as well, which is maybe a coincidence or maybe something to do with the therapy, but it's not something I can explain based on the treatment and the findings. So at that time I saw, well, this young guy with Jacobsen syndrome with an immunodeficiency. And I thought, no, why is this guy having both an immunodeficiency and a Jacobsen? Because Jacobsen is a rare disease, immunodeficiencies are rare diseases, so maybe there is a common link. So what I did at that time is I went into literature to see whether are there any other cases described in medical literature describing immunodeficiencies in patients with Jacobsen syndrome, and indeed there was. I show you some examples of cases already known for some years, like for instance this is a publication from 1998, so already over 16 years ago. A 12-year-old girl with indeed recurrent upper respiratory tract infections, and also found in the Schouten guy low immunoglobulin A and M levels. Another example published some years ago, a 12-year-old boy which was known for a long time with chronic diarrhea, recurrent upper respiratory tract infections, also since infancy. And when they checked for his immune status, you can see here clearly that his immunoglobulins are low. These are the normal values. IgG is low compared to normal, IgM low compared to normal, and IgA is in the normal limits. So, but again, low IgG, low IgM, recurrent respiratory tract infections, and recurrent gastrointestinal tract infections. Another example, 5 years ago, with a 4-year-old boy with a known Jacobsen syndrome, with recurrent respiratory tract infections with low levels of IgG, and another 5-year-old boy with Jacobsen syndrome, with indeed bacterial infections, also with low immunoglobulin levels. So some cases with recurrent infections, low IgG, low IgA, low IgM. And if you go back in literature, an example of a table from a publication by Paul. In 2004, it was demonstrated that indeed in 78 patients analyzed, 42 of patients had recurrent infections. So a majority of patients with Jacobsen syndrome seem to have recurrent respiratory tract infections. And some very recent examples, this is a newborn girl from Thai Australian father and mother with Jacobsen syndrome, with also low IgG, IgA and IgM. And a publication from the beginning of this year, a 45-year-old patient with recurrent pneumonia with low IgG, IgA, IgM. So in medical literature worldwide we see cases of Jacobsen syndrome, infections and immunodeficiencies. Most of the time immunoglobulin deficiencies based on defects in the production by B cells. So based on these findings and my interest in primary immunodeficiencies, I thought, well, let's try to analyze systematically the patients we have in the Netherlands with Jacobsen syndrome on immunodeficiencies. And with the help of the Dutch patient organization, until now I got 9 patients evaluated. I got the data from 7 patients I will present now. And what did we do? As I said, 9 patients, 7 patients we have the data. Next 2 I will present or I have the data for in 2 weeks, so I cannot show them today. What did we see in the patients? All patients, all 7, had since infancy recurrent respiratory tract infections. Some of them had recurrent infections of the gastrointestinal tract, and some of them, 2 out of 7, had recurrent warts on the hands. Warts are quite normal. I mean, all children, or almost all children, will have warts, but after some time you should get rid of them if your immune system develops in a mature immune system. So what did we do? We evaluated the infectious complications, so how many infections were they reported, how many times did they use antibiotic treatments, how severe were the infections, were there hospital admissions because of the severity of the infections. Then we evaluated immunoglobulin levels, numbers of immune cells, so the B and T cells, as shown previously, and the natural killer cells, which are responsible for detection and deletion of specific viral infections. So this is a slide I want you to remember because it's very important. But the only thing you should remember is that if you have development of B cells, it's a very complex pattern in which you have a stem cell which can generate all kinds of specific cells, and you have very many steps. An immature B cell has very many developmental steps to become a mature B cell. So the development can stop at any point, and you can have developmental disorders at various sites. So I needed you, the patients, and this is a patient you might know. This is Robin Olney, who was at that time living in Brussels, and now she's back in the United States. And what we do, we invited them to the outpatient clinics of our department. We spoke to them and we draw blood. So all of them recurrent infections, and these are the results I want to show. I have 2 adult patients and 5 patients between the age of 10 and 16 years of age, so I present them in different tables because the normal values are a bit different between adults and children. So these are the 2 adult patients that I saw. This is the Schouten guy. This is another female patient from our outpatient clinic, and what you see is that in this case the gray bar represents the normal values of immunoglobulins in this age. You see this one is low and this one is on the lower limit of normal. More clearly, I have the 5 children patients. All but 1 are low in total immunoglobulin levels. And actually this patient turned out to be not to be a true Jacobsen patient. This was a patient that turned out to have a duplicate of one of the chromosomes 11. So instead of 2, she had 3 chromosomes. So I would say from the 6 patients we have the data, all 6 have low or rather low immunoglobulin levels. I showed you in one of the first slides that the immunoglobulins are produced by the human B cells. So a normal reaction when you find low immunoglobulins, you want to know how many B lymphocytes do we have. So in adult patients, again, low and just a bit low, I would like to say, of number of total B cells. And in the children, again, this one turned out not to be a true Jacobsen syndrome patient, but all children have low number of B cells. So low number of B cells, and I think subsequently low number of immunoglobulins, as these are the immunoglobulin producing cells. Going back in your head to the very complicated slide showing all these steps of maturation of immature B cells, we evaluated all these steps of B cell development, and what we found was over here very clearly the number of memory B cells was low. So I showed you the total number of B cells, which was low, but what you see is that of all B cell subsets, the total number of memory B cells is low in the adults as well as in the children. T cell count was rather normal, a bit low in this patient, but rather normal in the children. So what is the conclusion until now? That most of the patients have recurrent infections, most of the patients have low IgG levels, and if you look at the B cells, the subset that is low are the number of memory B cells. So what's the importance of the memory B cells? I mean, you can imagine that indeed by defect in the production of total B cells, you get a reduction in the number of immunoglobulins levels, but the memory B cells are essential for generating memory, as is in the name. What does it mean? If you have a first encounter with a virus or a bacteria, your B cells start producing immunoglobulins, the proteins that can attack the bacteria and can get rid of the bacteria. But upon that first encounter, your B cells also start producing memory B cells. So if you get an infection with bacteria A, your B cells make proteins to get rid of bacteria A, but they also make memory B cells that can detect bacteria A, just to store in your body that in case you have a second encounter with that same bacteria, you have a faster and more efficient reaction to that same bacteria. So it prevents you from a secondary infection with that same agent. So your memory B cells are very essential for generating memory. So after a first encounter with a bacteria, it prevents you from getting sick or getting severely sick when you encounter that bacteria for the same time. So what you see in the Jacobsen patients we analyzed, you have a defect in the production of memory B cells. So there's a defect in generating memory. So when you get an infection for the second time or third time, you are less there is less prevention to the secondary encounter. So what did we see? Now increased risk of recurrent and severe infections because one, you have the low numbers of immunoglobulins, and second, you have the reduction of memory B cell formation, which gives you an advanced risk for respiratory tract infections, gastrointestinal tract infections, potentially skin infections, or other kinds of infections. So what can we do about it? Because we might have a problem, and the question is, can you do something about it? Well, as already introduced by Ken, if you have a limited number of infections a year, you can say, well, if we have only 2 or 3 infections a year, you can treat with on-demand antibiotics. If you have unsevere infections, I would say a sinusitis, uncomplicated, you can treat that infectious period or episode with antibiotics. If you have recurrent respiratory tract infections, I would suggest to use antibiotic prophylaxis. So start on a regular basis with the use of antibiotics, let's say for instance every day, low dose antibiotics to prevent you from getting sick. If that won't be enough, or you have recurrent severe infections, you might opt for an antibody treatment. So you can suppletion of these immunoglobulins that are missing or not functioning well. You can do it via the bloodstream, intravenously or subcutaneously. And the goal of the treatment is one, to reduce the number of infections and thus reduce number of hospital admissions, reduce the need for antibiotic treatments, and also it delays progression of chronic lung disease. I mean, you can imagine, again, recurrent infections leads to damage to the lungs. So, what are the future plans? So, we evaluated now 9 patients, and I think we can conclude that all patients have indeed respiratory tract infections, but you also find in a high number significant deficiencies in immune cell function. So, we are going to complete the analysis on all patients in the Netherlands, and then we are now setting up the international collaboration to evaluate immunodeficiencies. Yeah, I think we should do it worldwide, because the final thing is that we can look for an explanation. Why do the patients with Jacobsen syndrome have a higher incidence of development of immunodeficiency? Is it genetic, common genetic based finding? Is it the ETS gene, or are there other genes involved in development of immunodeficiency in Jacobsen syndrome? And to end with a recommendation, I feel at this point, based on the findings until now, so not only the Rotterdam findings, but also the described cases in literature, that all patients with a known Jacobsen syndrome should be referred to, or at least analyzed for by an immunologist for immunodeficiency, as I feel that in a certain way Jacobsen syndrome patients that all we see now and saw in the past have some form of immunodeficiency, and that's where I would like to end.
Yes, we have quite an active discussion here.
Last time we spent 2 hours fielding questions. We're going to have to narrow it, limit it to about 10 minutes for now, but I think we can.
I think what we should do is do the live stream ones, and then Virgil and I, if people have individual questions, they can grab us at any point and ask them face to face, or if it's something that people think would be good for the whole group, we can do a limited number here. Because I don't want to take up, there's other speakers.
Right, I mean, we could probably devote a whole day to this.
Yeah.
The first question comes from Marie in Australia, who watched your presentation a few years ago, and she's online this time as well. She wants to give Dr. Harris a huge thank you, as she found that Dylan had an immune deficiency and now receives weekly treatment, and his health has improved out of sight.
Great. Good.
Second one is, let's see here. So that skin infections aren't common, but our daughter is super susceptible to ringworm. Is that common with special needs children?
So ringworm is actually something that we often will see in patients who have T-cell dysfunction, very similar to the warts. It's a similar mechanism sometimes. So that would be on the list of things that I might want to get looked at.
Okay, she does say the second part. Our daughter's T cells are super low, but the immunologist said that the ones that need to work good, so we don't have to do anything for it. What course of action should we do now?
Let's see. The ones that need to work really good. I think they kind of all should work. Yeah, I don't know how. It's hard to interpret without knowing what kind of labs were drawn. So I think maybe a recheck might be.
How about sending you the information?
Yeah, it's true. If you want to email some info to me, that's absolutely fine. You can get in contact with Paul, or he has my email. It's simple.
And another one, is recurrent eczema a possible sign of immune deficiency? My daughter has always had small spots of eczema in random places on her body.
I'll take this one since he's an internist and not a pediatrician. So while there are immune deficiencies that have eczema as part of the constellation of symptoms, in Jacobsen syndrome, if you have eczema, I would not attribute to the immune deficiency. That probably is not really related. There are other skin rashes that can be confused with eczema that we see in immune deficient patients, but I don't, like for example, tinea or ringworm type infections, but immune deficiency and eczema in this disease I'm not so sure about. But there are some endocrinologic problems, so sometimes eczema can be seen in those diseases too. So that's it. Okay.
We have a few more minutes for questions from the group here.
I have a question about, in your studies so far, have you noticed any type of correlation in the patients that you've already examined and studied, highs and lows in the workability of the immune systems and when they have higher counts instead of others? I just noticed it in my daughter by cycles of there's periods where she's more infectious than other times.
Yeah, that's an interesting question indeed. Yeah, I didn't have the, well, what we did until now, we had only 1 point or 2 point evaluations. But what you see, it's a bit difficult to say because it's a little number of patients and we only have 7 patient data now. But what you, in your gut feeling, if you look at the figures, is that the lower the immunoglobulin levels, the more severe the infections and the more infections a year a patient suffers. That's also what we see in adult patients with common variable immunodeficiencies, or the primary immunodeficiency without an underlying Jacobsen syndrome, that the lower the number of B cells, the lower of immunoglobulins, the more serious infections patients experience. But it's only in these 7 patients, it's hard to conclude, to draw these conclusions, but that's what I feel.
Hi, thank you again for coming. I have a 2-part question. My son was tested a year ago, and I'm wondering, is this something that should become like a recurrent test every couple of years to monitor?
Yeah. That's a difficult question, actually. Also, because if you get born or when you are born, your immune system is very low. That's normal. So if you draw blood from a newborn baby, you have immunoglobulins which are very low. So in the years, it starts the levels of immunoglobulin start rising, also normally. So it's difficult to say when should you start drawing blood. Maybe the pediatrician can answer better, but then should you indeed repeat? Well, I feel if you once evaluated an immune cell dysfunction, or you said, well, there is low number of immunoglobulins, low number of B cells, I think you should regularly take a new blood to re-evaluate, because we know that if you have an immunodeficiency, it gets worse over time in general.
It does, okay.
Yeah.
How often then do you think? He's turning 8 this month, so he was 7 when he first had it done. Do you think like 2 years?
So
or?
what I do, but this is for adult patients, if I find an immunodeficiency, also without a clinical significance, so patients who have low immunoglobulins without infections, I start evaluating once every 12 months.
Okay.
Yeah, but maybe you think different about it?
Yeah, so if I diagnose a patient with a hypogammaglobulinemia or CVID or low immune or an immune deficiency, I monitor that every 12 months or so, sometimes sooner if infections change. If I were to see a patient with recurrent infections, the initial evaluation was normal or near normal, I maybe would not reevaluate unless this clinical picture changed or worsened. So if there was a change in the clinical picture, or what we call the phenotype of the patient, I would reevaluate it, because we know that things are not static. They change over time, and they can get worse. Specifically CVID and the hypogammaglobulinemias that are what most people with Jacobsen seem to have. Those are progressive in nature. or can develop in adults, even though there's a genetic basis to the disease Jacobsen syndrome. I think that it may be something that develops over time. I mean, you notice the ages of the patients that Virgil sees, they're adults, they're teenagers. They may have had fairly normal immunity early on. We don't know because we're now evaluating when they're older. So as time goes on, we'll get a better picture as to when the immune deficiency in Jacobsen develops. It may not develop within the first few years of life. It may develop over time. So we will learn that as time goes on.
How does that correlate to therapy treatment?
Just want to repeat it.
Yeah, so the question was, how does that relate to therapy treatment? It would be something that's why we need to keep checking, because the decision that we would make probably at the first evaluation, if we just found a mild hypogammaglobulinemia, we might choose prophylactic antibiotics. If we monitor that and we notice that there's a more significant deficiency that's developing, we may automatically switch to replacement of antibody with immunoglobulin. So that's why it's important.
Yeah, and if I may add something to that, because I just said that indeed, in general, you see the lower the numbers of immunoglobulins, the more severe the clinical picture is, but it's not always that it's that there is this association. So you sometimes see patients with relatively, well, they are lower than normal, but relatively high number of immunoglobulins, and they have still severe respiratory tract infections. So it's not said that if you have just a little bit lower, that the clinical picture is not severe. So in general, I would say there is a correlation between the number of immunoglobulins and severity of infections, but individually it can change.
So the functionality might be a question like
Exactly, that's what I say.
Yeah, exactly like that, yeah.
Yeah, so normals may be the levels of immunoglobulins may be normal, while function is defect.
Yeah. So that's, let's say one more thing. So that's why it's important to see a clinical immunologist, specifically one that we may have a relationship with through the JMF Center network, rather than just let a primary care physician or family practitioner or nurse practitioner order these tests because you said to order them and then not really know how to interpret them, because some of them may be near normal in number, but a clinical immunologist may want to treat your patient with either prophylactic antibiotics or even gamma globulin replacement based upon the severity of the infections. So I think most of our colleagues think the way we do in regards to treatment of patients with recurrent sinopulmonary infections and mild immunologic defects. So that's really important, is to see an immunologist.
I just wanted to chime in on a few things. One is with, I think, what are very clear recommendations now for all of your children getting a formal evaluation by an immunologist. I think when Chuck Haymeyer speaks to our group on Thursday, I would like to propose, like I did at the European conference, that we adopt a protocol, which again is a legally binding document to give you leverage to basically force your caretakers, and I think they'd be remiss not to follow this, to do that kind of systematic evaluation. And I'm hoping that these guys will help us to draft that with the specific medical content, and Chuck can put in the appropriate legalese like he did for the bleeding protocol. Secondly, as a direct offshoot of that, I think that would be incredibly powerful to have a way to funnel that information back to these guys so that obviously we can learn more. There's always strength in numbers. And lastly, just from the genetic standpoint, you know, there's several families here at this conference that have children with interstitial deletions, and I think that would be, just like what I think I've shown you for the cardiac story, very informative to see if there are clinical differences that correlate with the interstitial deletions. So. Were there any more questions? How about we do one more question, and I'm going to propose we take maybe a 5-minute break. I think we're still on time. Yeah? And then we'll move on. Go ahead, Jeremy.
I just had a real quick question. You had talked about the memory B cells. Is there a test for that? Because I've never heard of the test, or I've gotten 3 tests as far as immunology goes, and that test has never come up.
Now, if so, the number of memory B cells is a subset of the total number of B cells. So, on general evaluation, you get total number of B cells, total number of T cells, and maybe a total number of natural killer cells. And then you need a subset analysis of B cells. And in I don't know in all, where it is in all, but in some specific immunology labs, you can get all subsets of B cells. Yeah, but then you should really do it in a specific immunology lab, which is also interested in analyzing immunodeficiencies. So not all labs will tell you the number of B cells, the memory B cells. But if you, like Ken said, if you contact one of those GMF centers, I think all GMF centers are able to, or themselves, evaluate the number of memory B cells, or send the material somewhere else to one of the other centers that can measure the memory B cells. Yeah.
Thank you.
Thank you so much.
Thank you so much. Okay, so about a 10-minute break?
Yeah, that's good. Tell them 5, they'll be back.
5 minutes.
Yeah,